We are willing to talk to hospitals about the prospect of providing some relief, but understand, if any money is going to flow, there will be strings attached. None of this money, or any other in the future, will flow to any hospital unless it commits and adheres to clear accountability requirements. The accountability requirements are about a new relationship with our hospitals, a relationship that for the first time ties funding to results, rewards good performance, and has real consequences for poor performance. Here's how it would work. The Ontario government, the insurer, would enter into agreements with each institution to ensure targets are set for service delivery and volumes, as well as achieving key government priorities like a higher proportion of full-time nursing in exchange for funding. Like many of you would expect to see in your own businesses or homes, it would ensure a clearer recognition of the contractual nature between payer and provider. It would also ensure that there are penalties for those who fail to deliver on their commitments. It's funny how in some circles this seems like a radical concept. What's radical, I would suggest, is that it's never been done in Ontario before. Government must also change its behavior towards hospitals. In the past, the absence of stable, predictable funding has made it more difficult for hospitals to plan effectively, which often contributed to the deficit trap. Having clear rules for how hospitals are funded is an essential part of ensuring that they are given the resources to actually deliver on the requirements set out in their agreements. To that end, hospitals have been working with government through the Joint Provincial Planning Committee on a new, more predictable method of funding hospitals that enables longer-term planning and links funding to quality results. Make no mistake, accountability and predictable funding must go hand in hand. We believe that transformation must begin with making hospitals, the largest component of our healthcare system, sustainable and accountable for delivering results. Now, in fairness to hospitals, I recognize that many of them have been put in an untenable position. They've been forced to pick up the pieces when other parts of the healthcare safety net weren't available to deliver effectively. This has resulted in cost pressures while hospitals expanded services to meet growing demand. Our plan to introduce accountability agreements is not to pick on or to punish hospitals. Instead, it is to bring clarity to the relationship in order to secure mutual benefits to both hospitals and to the public. For too long now, we've been treating symptoms, not causes. A bit like cranking up your furnace in the middle of February, only to discover that the real thing you need to do is close the windows. It's time to take a step back and get our house in order. Therefore, this commitment to predictable funding will be accompanied by an equally firm commitment to reinvestment in the complementary, community-based services needed to allow hospitals to do what they do best. Hospitals are expensive places to treat patients, yet far too many hospital days are taken up by patients who don't need to be there at all. Institutional long-term care and home care supports are two examples of alternatives that can facilitate safe and appropriate early discharge from hospital. Furthermore, community and home supports can help keep people out of institutions in the first place. The evidence is overwhelming that these can be cost-effective alternative approaches. So why are we not taking better advantage of these options? By taking steps to put these community and home supports in place, we can reduce the unfair and unnecessary burdens placed on our hospitals, allowing them to plan their budgets and serve their patients more effectively. Furthermore, by doing this, we can act in the better interests of patients' health and comfort. Before I leave the section on hospitals, I'd like to say something very, very clearly, and I'd like to send a message very specifically to those hospitals in Ontario who year in and year out have balanced their budgets. Some of whom will view our talk of dealing with deficits in 03-04 as a reward for behaviors that they did not participate in. We don't view it that way, but I would like to send the strongest message possible, a message of thank you, a message of thanks to those hospital administrators that have not exhibited those same needs. I'd like to talk secondly about accountability and outcomes. The second change strategy focuses on making our healthcare system more accountable, more focused on outcomes, and more committed to quality care. Often it's been difficult to develop and execute accurate methods to measure our system's outcomes. Things like quality were difficult to judge and difficult to quantify. And even things like wait times were impossible to measure with any real accuracy. We need clearer performance targets, greater transparency, and better lines of communication. It's time to actually transform our healthcare system into a system focused on results. Results-based planning focuses on achieving results in priority areas rather than the scattergun approach of the past. It makes sure that the money we spend achieves measurable and meaningful results that people care about. It gives Ontarians some clear and easy measures to check government's progress and to hold us accountable too. Bill 8 plays an important role in our results-based planning agenda by creating the Ontario Health Quality Council, an independent, arm's-length body responsible for reporting on important health quality indicators to assist us in raising the quality of our healthcare system. The Council would measure the effectiveness of the system and report on its performance in priority areas that Ontarians tell us they care about most. Finally, we're working on a new strategy to create incentives and rewards in the system, allowing us to target resources towards particular challenges. I've talked about how Ontario's hospitals will be required to meet performance goals, including targets for better managing clinical and human resources, namely creating full-time nursing positions. And results-based budgeting will be extended to the entire public health care system. All healthcare providers will be made accountable for how well they work together to meet the needs of patients. Information technology will be a major enabler because it allows health providers to talk to each other and share information. It will also revolutionize our ability to evaluate system performance. That's why we will put health information technology integration in full forward gear. It's an ominous sign for all of you. There are 2 glasses of water. The third area of reform is what I call the transition to community. There's one basic solution to making care more effective and more sustainable. It's this: putting it into the community. I haven't been the Minister of Health for very long, but one thing I know is that Queen's Park certainly does not have all the answers, and I think it's time we acknowledge that. I'm a great believer in government, and I can tell you that the people in my ministry are some of the brightest and most committed public servants I've ever encountered. But trying to run Ontario's healthcare system from a suite of offices at Queen's Park is a little like trying to shave while blindfolded. You're not quite sure what you're doing, and the risk of slipping up is enormous. What's needed is better integration and planning at the local level so that we can deliver better results in each part of our province. Not a regionalization model, a made-in-Ontario solution that builds on the strength of our community-based organizations, large and small. As Romano showed us, primary care renewal is the foundation on which the transformation of our healthcare system must rest. At its heart, it promises to improve access to primary healthcare services and prevention, and serve as the golden thread that will help weave the disparate parts of our healthcare system together. Our government will move decisively on primary care renewal by acting on our commitment to create family health teams that will provide comprehensive family health services around the clock. This approach will allow physicians to work as part of a team with other health providers rather than in the isolation of sole practice. Physicians, nurse practitioners, and other members of the team will benefit by working together in a positive working environment, sharing and benefiting from the complementary knowledge and skills of their colleagues. And patients will benefit too by having improved access to a range of family health providers that will care for them when they are ill and help them stay healthy in the first place. The Federal Health Accord allocates money to expanding primary care reform, and we will take full advantage of it. Effective home care services are also very much a part of our plan for putting care in the community. Romano calls health care, home care rather, the next essential service, and we agree. Nowadays, services that used to be only provided in institutions can be delivered at home. Home care can offer greater